Welcome back to the deep dive. Today we are focusing on something that is, well, it's literally right in front of your nose and on your nose and holding your entire body together.
We're talking about the skin.
We are talking about the skin, but we aren't talking about it in the way you might see in a magazine, how to get a glow or anti-aging secrets.
No, we're going way, way deeper than that.
We are looking at the skin as an organ that is actively fighting the world. It's a shield, sure.
Of course.
But it's also a sensor. It's an immune organ. It produces hormones. And today we are tackling the pharmacology of how we treat this incredible barrier.
It is a fascinating topic because it presents this unique engineering problem.
An engineering problem? How so?
Well, the skin evolved over millions of years to keep chemicals out. That is its primary job description. Do not let the outside world in. And yet, as pharmacologists and as clinicians, our goal is often to force chemicals in to treat a disease.
So we're trying to break into the fortress.
Exactly.
Without destroying the walls.
That is the core tension of dermatological pharmacology, right there. It is all about boundary management.
To guide us through this boundary management, we have our two standard heavy hitters. We are looking at Katsung and Trevor's Basic and Clinical Pharmacology, specifically the chapter on Dermatologic Pharmacology. And we were pairing that with Goodman and Gilman's The Pharmacological Basis of Therapeutics, the chapter on Dermatological Pharmacology.
And this is a really, really great pairing for this specific topic. You absolutely need both perspectives here.
I noticed that immediately. Reading through them, Katsung feels like the practical guidebook.
Yeah, the clinical scaffolding.
Exactly. It gives you the tables, it organizes the drug classes, it tells you, here's class 1, here's class 7, here's what you prescribe for psoriasis.
It helps you survive the ward round. It's what you need on Monday morning.
Right. But then you open Goodman and Gilman, and it takes you down to the molecular level. It explains why the class 1 steroid is so much stronger. It explains the nuclear receptors.
It gives you the systems level reasoning. The deep why.
So our mission today is to act as the bridge between those two. We want to synthesize the how from Katsung with the why from Goodman and Gilman. We aren't replacing the reading.
No, absolutely not.
You still have to grapple with those chapters, but we want to give you the conceptual map so that when you do read them, it clicks.
Right. We want you to move from just memorizing drug names to really understanding the physiology of the barrier. Because if you understand the barrier, the drugs make sense.
And the theme we're going to keep coming back to is this idea of the barrier that remembers.
Which sounds a little bit ominous.
It does, but it's true, isn't it? The skin has a memory. It remembers what you put on it yesterday because of the reservoir effect. It remembers the sun from 10 years ago. It remembers the allergen that touched it last week.
It's a dynamic history book, and we're trying to edit the text without tearing the pages.
Okay, so before we dive into the specific drugs, the vehicles, all of that, I want to start with a number, a single data point from the text that actually made me stop and reread the paragraph.
I have a feeling I know which one you're going to cite.
It was in the section on regional variation and absorption.
Oh. Yeah.
So they set the forearm as the baseline. The standard, let's say the absorption of hydrocortisone on the forearm is a value of 1.
1 unit of absorption.
Then they looked at the scrotum.
The anatomic region with the highest permeability.
The absorption score was 42.
42 times the baseline.
It's just staggering. If I put a gram of hydrocortisone on my arm, I get a certain exposure. If I put that exact same amount on the groin, I am getting 42 times the dose absorbed into the tissue.
It effectively becomes a systemic injection at that point. The dose is that high.
So why? What is going on there? Is the skin just that much thinner?
Thickness is a huge part of it, certainly. The stratum corneum on the scrotum, and on the eyelids for that matter, is incredibly thin compared to, say, the skin on your back or your arm.
Okay.
But it's not just about thickness, it's about architecture. You have to consider what the texts call the shunt pathways.
The shunt pathways.
Yeah, the hair follicles and the sebaceous glands. So imagine the skin barrier, the stratum corneum, as a solid brick wall. It's hard to get through.
Right.
But a hair follicle, that's an open elevator shaft that goes straight down into the dermis. It completely bypasses the security checkpoint of the stratum corneum.
Ah, so it's a shortcut.
It's a massive shortcut. In areas with high follicular density like the scalp, the face, and yes, the scrotum, are like sieves compared to the forearm, which is more like a solid sheet.
So when we talk about skin, we are making a huge mistake if we think of it as one uniform thing.
A huge mistake, and a dangerous one clinically. If you prescribe a super potent Class 1 steroid for a rash on someone's back, that might be appropriate. The skin is thick, absorption is moderate.
But if you tell that patient, oh, just put this cream wherever you have a rash, and they put it on their face or their groin.
You're overdosing them dramatically.
Yeah.
You will cause skin atrophy, you'll get systemic absorption, you could suppress their adrenal glands. The rules of entry change completely depending on the geography of the body.
Okay, let's zoom in on this brick wall you mentioned. This is the stratum corneum. The texts both call it the rate-limiting step for absorption.
Right. This is the absolute outermost layer of the epidermis. And for a long time, people just thought of it as dead skin, just a passive wrapper.
Like a layer of plastic wrap.
Exactly. But it's not. It is a highly engineered biological fabric. The bricks are the cornucytes. These are dead cells, flattened and packed with keratin protein. And the mortar between them is this complex, highly organized mixture of lipids, ceramides, and fatty acids.
So for a drug to get in, it has to navigate that mortar.
Exactly. Unless it's small enough to go down a hair follicle, the drug has to wind its way through that lipid matrix. It is a tortuous path. It's not a straight line from A to B.
So it favors things that, like fat, that are lipophilic.
It heavily favors them.
But let's say we get past the wall. We're in. Are we home free? Does the drug just flood the system?
Not at all. Now you hit the living epidermis. This is about 100 micrometers thick. And Goodman and Gilman makes a really, really important point here. The epidermis is not just a sponge waiting to soak things up.
Right.
It is a metabolic factory.
This is the concept of biotransformation in the skin.
Yes. The skin has its own liver-like enzymes. Specifically, it has cytochrome P450 enzymes.
Just like the liver?
Just like the liver. There's one called CYP26A1, for instance.
Catchy name.
Pharmacologists love their acronyms.
Uh-huh.
But this enzyme, CYP26A1, exists specifically to metabolize retinoic acid. So imagine you apply a retinoid cream for acne.
Okay.
Before that drug can even reach its receptor to do its job, the skin's own enzymes might chew it up and deactivate it.
Or the opposite could happen, right? The skin could activate a prodrug.
Correct. The skin can take an inactive molecule and metabolize it into the active form. So the skin is an active participant in the pharmacology. It's interacting with the drug, metabolizing it, sometimes even pumping it back out with transporter proteins.
It really is a fortress. It has walls, it has guards, it has shredders for unwanted mail.
That's a great analogy. And then, only if you get past all of that do you reach the dermis. And that's where the blood vessels are. That's where the systemic absorption happens. It's also where the immune cells, like mast cells, are hanging out. If the drug gets here, it can enter the circulation and go to the rest of the body.
Which brings us to the physics of how we force things through this fortress. The texts both mention Fick's law.
Fick's law of diffusion.
Now, I'll be honest, when I see physics equations in a medical text, my eyes tend to glaze over. But this one seems pretty fundamental to understanding why we prescribe what we prescribe.
It is the governing equation of dermatology. It's actually pretty simple in concept. It basically says that the fluxo, the amount of drug moving across the barrier per unit of time, is dependent on the concentration gradient.
So a higher concentration on the outside equals more absorption.
Think of it as pressure. If you have a high concentration of drug on the surface and zero concentration inside the skin, you have a massive gradient. That gradient acts like a physical force, just pushing the molecules into the skin.
So if I have a patient with a really thick, stubborn plaque of psoriasis on their elbow, and the 0.1% cream isn't working,
you might switch to a 0.5% cream. You are literally increasing the chemical pressure to overcome the resistance of that thick disease barrier.
There's another variable in Fick's law that we can manipulate, though, the partition coefficient.
Right, and this is a bit more subtle. This is how much the drug likes the skin versus the vehicle it's sitting in.
How it divides itself between the two.
Precisely. The stratum corneum is fatty. It's lipophilic. So generally, drugs that are also lipophilic will move into it more easily from a watery vehicle. You need that balance where the drug is willing to leave the vehicle, but also soluble enough to travel through the skin.
This all leads to the reservoir effect. This was one of those aha moments for me reading the chapter.
It is crucial for understanding dosing schedules. It's a game changer.
So explain this. How does the skin act like a reservoir?
Because the stratum corneum is this fatty layer, it can act like a sponge for lipophilic drugs. You apply a steroid cream, the drug moves into the stratum corneum. But it doesn't all go through immediately. A lot of it just sits there, trapped in that lipid matrix.
So you essentially create a depot, a little pocket of drug inside the dead layer of the skin.
Exactly. And that depot then slowly releases the drug into the deeper living layers over time. So even if you wash your hands, even if you wipe the surface cream off, the drug that's already partitioned into the stratum corneum is still trickling down.
And that explains why we can prescribe so many topical steroids for just once-a-day application.
Yes, in the old days we might have said apply 3 or 4 times a day. But then studies show that for many of these drugs, once daily is just as effective.
Because the reservoir does the work for you.
It maintains that steady state of delivery long after the initial application.
That's incredibly efficient. But sometimes we need to go nuclear. We need to force the door open, and that is where occlusion comes in.
Occlusion is the sledgehammer of dermatological pharmacology.
This is basically just wrapping the skin in plastic, right? Like saran wrap.
Saran wrap, a hydrocolloid dressing, a waterproof bandage, or even just a really tight, non-breathable piece of clothing.
Or, if you are an infant, a diaper.
A diaper is the ultimate occlusive dressing. That is precisely why diaper rash or diaper dermatitis is so common and can be so severe. It's a constantly occluded environment.
Right.
But clinically, we can use this to our advantage. If you cover the skin with an impermeable barrier, you prevent sweat and transepidermal water from evaporating.
So the skin just marinates in its own moisture.
That's a perfectly vivid way to put it. The stratum corneum hydrates, those dead cells swell up with water, and when they swell, the network of lipids loosens. The barrier function plummets.
How much of a difference does this really make?
It can increase absorption by tenfold.
10 times, just from adding a piece of plastic wrap.
Yes. So if you have a patient with something like lichen simplex chronicus, this incredibly thick, leathery patch of skin from chronic scratching, a normal cream might not penetrate at all.
The wall is too thick.
The wall is too thick. But if you put the cream on and wrap it in plastic overnight, you hydrate the barrier, you open the gates, and the drug floods in. It can be the difference between treatment success and failure.
But there has to be a downside.
There is always a downside. You are creating a warm, moist, dark environment.
A tropical vacation for bacteria.
Precisely. So the risk of infection folliculitis, in particular, goes way up. And if you do it for too long, the skin macerates. It turns white and mushy and starts to break down.
So it's a powerful tool, but a risky one.
Very risky. You use it for short periods on specific resistant lesions.
So we've talked about the barrier, and we've talked about the physics of entry, but we haven't talked about the delivery truck yet. We need to talk about the vehicle.
I would argue the vehicle is just as important as the drug. In some cases, maybe more so.
Katzung makes this point explicitly. You can ruin a perfect drug by putting it in the wrong vehicle.
Absolutely. The vehicle determines the rate of release of the drug, it determines the hydration of the stratum corneum, and maybe most importantly, it determines whether the patient will actually use the medication. Adherence.
Let's walk through the spectrum. We usually categorize these from greasy to watery. At the greasy end, we have ointments.
Ointments. This is your petrolatum, your Vaseline. It is almost entirely lipid or oleaginous, as the texts say, very little, if any, water.
These are the heavy tanks of the vehicle world.
They are. They are occlusive by their very nature. Even without plastic wrap, a thick layer of ointment traps moisture. So they are the best at hydrating the skin. They give you the greatest penetration enhancement.
So why don't we just use ointments for everything?
Because they are, frankly, awful to wear. They are greasy, they shine, they get on your clothes, they ruin your bed sheets. Patients generally hate ointments unless their skin is so dry and cracked that the relief is worth the mess.
Okay, so we compromise. We give them creams.
The crowd pleaser. A cream is an emulsion. It's either tiny oil droplets suspended in water or water droplets suspended in oil.
Right.
When you rub it in, the water component evaporates and the oil phase vanishes into the skin. It feels light. It's what people call cosmetically elegant.
But chemically, it's a bit of a mess, isn't it, to keep that stable?
It's a huge chemical challenge. Oil and water do not want to mix. So to keep them stable in a tube on a pharmacy shelf for 2 years, you have to add emulsifiers, you have to add stabilizers. And because there's water, you have to add preservatives like parabens to stop mold and bacteria from growing in the tube.
And those additives are often allergens.
Exactly. So you can have a patient who is allergic to the preservative in their steroid cream. You prescribe the cream for a rash, and the rash gets worse and worse. You think the drug isn't working or the disease is progressing.
But actually, the vehicle itself is causing an allergic contact dermatitis.
It's a classic clinical trap. And one of the first things you should think about if a patient's eczema gets worse on a cream is to try switching them to an ointment. Ointments have far fewer preservatives because bacteria don't grow well in pure grease.
Okay, then we have the really drying agents. Gels, lotions, foams, solutions.
Right. These are usually alcohol-based or have a very high water content. They evaporate almost instantly.
Who are these for? Where do they shine?
Hairy areas. You cannot put an ointment on someone's scalp. It's a disaster. You need a foam or a solution that can get to the skin without matting the hair.
Okay.
But the alcohol stings. If you put a gel on raw, open, eczemated skin, the patient will scream. It can be very, very irritating.
This all leads us to what the texts call the golden rule of dermatology, the wet-dry principle.
Yes, if it is wet, dry it. If it is dry, wet it.
It sounds like a riddle, but it is the absolute foundation of topical therapy.
It is. You have to master this.
So let's unpack it. What counts as a wet lesion?
Think of an acute inflammatory reaction. Poison ivy. A fresh blister. An infected eczema flare. It is oozing serum. It is weeping. It is crusting. It is physically wet to the touch.
And if I put a thick, greasy ointment like Vaseline on that?
You are sealing in the heat. You are sealing in the bacteria. You are preventing the exudate from draining and drying. You will create a macerated, infected swamp. You are helping the bacteria, not the patient.
So for a wet lesion, I need a vehicle that evaporates.
Right. You want a tincture, a wet-to-dry dressing, a lotion, something that pulls moisture away from the skin as it evaporates. You want to dry out that vesicle and form a stable crust.
And conversely, if it is dry...
Now we're talking about chronic inflammation, psoriasis, like lichenified eczema from scratching. The skin is thick, it's scaly, it's cracked. The barrier is broken because it's brittle and dehydrated.
You need to add moisture back in.
You need to restore the moisture and the lipid barrier. You need an ointment or a thick cream to hydrate and plasticize the skin to make it flexible again.
It seems so simple, but matching the vehicle to the stage of the disease is half the battle.
It really is. You can prescribe the strongest steroid in the world, but if you put it in an alcohol gel and tell a patient to put it on a cracked, dry fissure on their hand, they will use it once, feel that intense burn, and never touch it again. Adherence falls to zero. The best drug is useless if the patient won't use it.
Okay, let's talk about the drugs themselves now, and we have to start with the backbone of dermatology, glucocorticoids.
Topical steroids, yes. They are the bread and butter.
So, the mechanism of action, we all know they reduce inflammation, but Goodman and Gilman dives into the nucleus here. What's actually happening?
So steroids are lipophilic molecules. They slide right through the cell membrane, no problem. Inside the cell, they find a glucocorticoid receptor floating around in the cytoplasm. They bind to it.
And then what?
That new drug receptor complex marches right into the nucleus of the cell.
And it starts pulling levers on the DNA.
Exactly. It's a transcription factor. It binds to the DNA and does two main things. It turns off the genes that make inflammatory cytokines. Things like interleukins and TNF-alpha, the alarm bells of the immune system.
Well, silences the alarms.
Right. And at the same time, it turns on the genes for anti-inflammatory proteins. So it's a double whammy.
And the texts also say they stop cells from dividing.
The antimitonic effect. That is key for a disease like psoriasis, where the fundamental problem is that the skin cells are dividing way too fast. The steroid puts a brake on that cell cycle.
So they stop inflammation, they stop division, they calm the immune system. It sounds perfect.
It is perfect until it isn't. Because those same mechanisms that treat the disease are the very same mechanisms that cause the toxicity.
Let's talk about the potency ladder. Katzung organizes steroids into classes, usually 1 through 7.
And this is not like extra-strength Tylenol, where it's just a little bit stronger.
Yeah.
The difference between a Class 1 super-potent steroid like clobetasol propionate and a Class 7 steroid like 1% hydrocortisone is astronomical.
Yeah.
We're talking hundreds, maybe even 1,000 times more potent.
And the potency isn't just about the molecule itself, is it? It's the vehicle again.
Yes. You can have the exact same molecule betamethasone dipropionate, for example. You put it in an optimized ointment vehicle, it's a Class 1. You put it in the lotion, it might drop all the way to a Class 5. The vehicle determines how much drug actually gets to the receptor.
So what is the clinical strategy? Do we start low and go slow?
Not always. For acute flares, the current thinking is often hit it hard and fast.
Get control.
Get control. Use a potent steroid for a short period to induce remission, put out the fire completely. But you cannot stay there. Once the fire is out, you have to taper. You drop to a lower potency class, or you switch to intermittent dosing, like on weekends only.
Because if you stay on a Class 1 steroid for months...
You will destroy the skin. The most common and most feared local side effect is atrophy.
That's the cigarette paper skin.
Exactly. The skin becomes thin, shiny, almost translucent and wrinkled. You can see the tiny veins underneath. Those are called telangiectasias.
And what causes that?
It's that antimitotic effect and more. The steroid inhibits the fibroblasts in the dermis. It stops them from making new collagen. You are literally turning off the structural maintenance program of the dermis.
And once that collagen is gone,
It often doesn't come back. Atrophy can be permanent. This is a very serious side effect,
we also see things like steroid acne or steroid-induced rosacea.
which is so ironic because patients will often put a strong steroid on their acne to treat the redness. But what happens is the steroid suppresses the local immune system, which allows the bacteria in the follicles to overgrow. Then when they stop the steroid, they get a massive rebound inflammation that's much worse than the original pimple.
Now, what about systemic risks? Can a cream really mess up your whole body's hormones?
Absolutely. If you apply a potent steroid to a large surface area, say the whole back of a patient with psoriasis, or if you use it under occlusion, you can absorb enough of the drug to suppress the HPA axis.
The hypothalamic pituitary adrenal axis.
Right. Your body's own thermostat for cortisol.
Yeah.
The body senses all this external steroid and thinks, oh, I have plenty of cortisol floating around. I don't need to make any.
So the adrenal glands go on vacation.
They atrophy. They stop making endogenous cortisol. And then, if the patient suddenly stops the cream or gets sick or has surgery, their body can't mount a stress response. It can lead to an adrenal crisis, which is a medical emergency.
And in kids, this is even scarier.
It's much scarier because of the surface area to body weight ratio. A baby is basically all skin. A single tube of a potent steroid represents a massive dose relative to their small body weight. You can actually cause growth retardation in children with aggressive or inappropriate topical steroid use.
There is one more concept with steroids that I found really fascinating: tachyphylaxis.
Ah, yes. The law of diminishing returns.
The skin basically gets bored of the drug.
It adapts. That's a great way to think about it. If you hit the glucocorticoid receptors with the same strong signal day after day, week after week, the cell down-regulates the receptors. It literally pulls them back inside the cell. It stops listening.
So the drug stops working as well.
Exactly. The patient says, this cream was a miracle for 2 weeks, and now it does nothing.
So the answer isn't use more drug or stronger drug.
No. The answer is give it a break. You need a drug holiday to let the receptors reset and come back to the surface. That's why pulse dosing, like 2 weeks on, 1 week off, can be so effective for chronic conditions. It prevents tachyphylaxis.
Let's pivot to a different class of drugs that also messes with nuclear receptors: retinoids.
Vitamin A derivatives.
Yeah.
These are the master regulators of epithelial growth and differentiation.
We use them for everything from acne to psoriasis to sun damage and wrinkles. How do they work?
They work in a way that's conceptually similar to steroids in that they bind to nuclear receptors. But they're different receptors, the RARs, the retinoic acid receptors, and the RXRs, the retinoid X receptors.
Okay.
And by binding to these, they essentially reprogram the gene expression of the keratinocyte, the main skin cell.
What is the goal of that reprogramming? What are we trying to fix?
In acne, the problem is something called abnormal follicular keratinization. The cells lining the inside of the pore are sticky. They don't shed properly. They build up and clog the drain, forming a microcomedo.
The start of every pimple.
The start of every pimple. Retinoids normalize that keratinization. They make the cells less sticky so they flow out properly. They are, in effect, sophisticated pipe cleaners.
Pipe cleaners, I like that. But they also treat photoaging. That's a different mechanism, right?
It is. They inhibit a transcription factor called AP1.
Yeah.
Now, AP1 is responsible for producing collagenase, the enzyme that literally eats your collagen.
The bad guy.
Bad guy. UV light from the sun activates AP1. Retinoids block it.
So they stop the destruction of collagen, and they also stimulate fibroblasts to make new collagen. They literally thicken the dermis over time.
They do. They're the only topical agents we have that are proven to truly reverse some signs of aging at a histological level.
But the side effects, they're notorious.
They are very irritating. Almost everyone who starts a topical retinoid gets retinoid dermatitis. Redness, peeling, flaking, burning. Patients hate it. You have to educate them that this is part of the process. It's called retinization. You have to push through it.
But the big warning, the one in all caps with flashing lights in the text, is teratogenicity.
This is non-negotiable. Systemic retinoids, like isotretinoin, which was formerly Accutane, or acitretin for psoriasis, are some of the most potent human teratogens known.
Meaning they cause birth defects.
Severe birth defects,
Yep.
craniofacial abnormalities, heart defects, central nervous system problems, they are absolutely 100% contraindicated in pregnancy.
And there was a specific story in Goodman and Gilman about acitretin that absolutely terrified me, the 3-year rule.
This is a pharmacological horror story. It's a perfect example of how drug metabolism can create a massive clinical problem.
And so what happens?
Acitretin is a drug we use for severe psoriasis. Now, normally, most drugs clear the system in a matter of days or weeks, but acitretin has a very weird interaction with alcohol.
With ethanol.
With ethanol. If a patient takes acitretin and drinks alcohol, even a glass of wine, the liver enzymes perform a reaction called transesterification. They combine the drug with the alcohol to create a brand new molecule called atretinate.
And atretinate is the problem.
Atretinate is the problem. It is extremely lipophilic. It loves fat, so it sequesters itself deep in the adipose tissue of the body. And because it's hiding in the fat, it doesn't get excreted by the kidneys. The half-life is massive.
How massive?
It can stay in detectable levels in the body for years.
So if a woman takes this drug for her psoriasis, has a glass of wine with dinner, and creates this metabolite,
She cannot safely get pregnant for 3 years after stopping the medication. 3 years. And she can't donate blood for 3 years in case a pregnant woman receives her blood.
that is an unbelievable burden. You aren't just prescribing a pill, you are prescribing a lifestyle change and a 3-year reproductive contract.
Exactly. It completely changes the risk-benefit calculus for a woman of childbearing age. You would almost certainly choose a different drug, like a biologic, just to avoid that specific long-lasting risk.
Okay, let's move from rewiring the skin to the war on the barrier. Let's talk antimicrobials, specifically the battle against acne vulgaris.
Right. The main enemy here is a bacterium called Cutibacterium acnes. It used to be called Propionibacterium acnes.
Right.
It's an anaerobic bacteria that lives deep in the follicle where there's no oxygen, and it feeds on the sebum your skin produces.
We have a few key weapons, benzoyl peroxide, topical antibiotics, and oral tetracyclines. Let's distinguish them. Benzoyl peroxide, or BPO, seems to be the old, reliable workhorse.
BPO is essentially a chemical grenade. It penetrates the follicle and breaks down, releasing free radical oxygen. Since the C. acnes bacterium is anaerobic, the oxygen is directly toxic to it. It kills via oxidation.
And the beauty of a grenade is that the enemy can't really learn to dodge it.
Exactly. There is no significant bacterial resistance to benzoyl peroxide. It's just simple, brute force chemical destruction. It's also mildly chemolytic, meaning it helps unclog the pores.
Contrast that with topical antibiotics like clindamycin or erythromycin.
These work by very specific mechanisms. They bind to the bacterial ribosome and inhibit protein synthesis. The bacteria can, and absolutely do, mutate their ribosomes to get around that.
So resistance is a huge problem.
It's a massive problem. If you use clindamycin alone as monotherapy for acne, you will breed a population of resistant superbugs on that patient's face within weeks to months. It's a guarantee.
So we pair them.
You almost always pair a topical antibiotic with benzoyl peroxide. The BPO kills any strains that might be resistant to the antibiotic. It essentially protects the antibiotic from becoming useless. Never use topical antibiotics as monotherapy for acne.
Then we have the oral tetracyclines, doxycycline, minocycline. But the text mentions something really interesting. We often use them at sub-antimicrobial doses. What does that mean?
This is a crucial nuance. At high doses, yes, they kill bacteria. But it turns out that at lower doses, they have powerful anti-inflammatory effects that are independent of their antibiotic activity. They inhibit neutrophil migration, they inhibit metalloproteinases, which are enzymes that break down tissue. So in acne, and especially in rosacea, we aren't necessarily trying to sterilize the skin. We're trying to cool down the inflammation.
We're using the side effect, the anti-inflammation, as the main effect?
Precisely. And by using a lower dose, we reduce the antibiotic pressure and hopefully slow the development of resistance.
Speaking of bacteria, I want to touch on mupirocin. This drug seems to have a very specific and important job.
Mupirocin is great. It has a unique mechanism, inhibiting bacterial protein synthesis in a different way. It's fantastic for impetigo, which is usually caused by staph or strep, but its real claim to fame is nasal decolonization.
Clearing the carrier state of MRSA.
Right. Staphylococcus aureus, including the resistant MRSA strains, loves to live in the nose. It colonizes the anterior nares. Patients can be asymptomatic carriers, but they keep reinfecting their own skin wounds, or they can spread it to others in the hospital.
So before a major surgery like a heart surgery or a joint replacement.
We often treat the patient's nose with mupirocin ointment for several days beforehand to wipe out that reservoir and reduce the risk of a postoperative infection.
Again, treating the reservoir. The theme just keeps coming back.
Always find the reservoir.
Let's jump to the alternatives to steroids. The immunomodulators, we have the calcineurin inhibitors like tacrolimus and pimecrolimus. Why bother with these if steroids work so well?
Because of the atrophy. Remember the eyelid. Remember the face, the groin, the armpits. These are all areas where the skin is thin and sensitive.
Right.
If a patient has eczema on their eyelids, you absolutely cannot put a medium or high-potency steroid there for any length of time. You will cause skin thinning, and you can even cause glaucoma and cataracts if it's absorbed into the eye.
So tacrolimus is the steroid-sparing agent for sensitive sites.
Exactly. It works by inhibiting T-cell activation through calcineurin, which is a different pathway. So it's a potent anti-inflammatory, but it does not shut down collagen production. It does not cause atrophy. It is safe for the eyelids, the face, and other thin-skinned areas.
But it comes with the black box warning, which always scares patients.
It does. When these drugs were first approved, the FDA put a warning on the label regarding a theoretical risk of lymphoma and skin malignancy. This was based largely on animal studies using very high systemic doses.
And what has the real-world data shown?
Large, long-term studies in humans using the topical preparations haven't really shown a significant signal for increased cancer risk. But the warning remains, and it's something you have to discuss with the patient.
And it burns.
It stings like crazy on the first few applications. And the irony is that you use it on inflamed, broken skin, which is the most sensitive. You have to warn the patient. It will burn for the first 3 days, then it will stop. If you don't warn them, they'll use it once and throw it away.
Then we have the smart bombs, the biologics. Things like dupilumab for eczema or the TNF inhibitors and IL-17 inhibitors for psoriasis.
These have revolutionized severe dermatology in the last 20 years. Instead of using a steroid that suppresses everything, the carpet bomb approach, these drugs are injectable antibodies that target one single molecule in the immune cascade.
Like taking out the keystone of an arch.
It's exactly like that. For psoriasis, you can say, I'm going to find and neutralize every molecule of interleukin-17. And when you do that, the whole wall of psoriatic inflammation collapses. They are incredibly effective for severe disease.
But when you turn off a very specific and important part of the immune system, you leave a blind spot.
You do. You create a vulnerability, you risk infection. And specifically, you risk the reactivation of latent infections that the immune system was keeping under control.
Tuberculosis being the classic example.
TB and hepatitis B. The body walls off TB and granulomas. It basically puts the bacteria in a jail cell. TNF-alpha is one of the guards keeping that jail cell locked. If you give a TNF inhibitor, the guard goes on break, and the TB can break out and cause active disease.
So you have to screen every single patient before starting these drugs.
It's mandatory. Chest x-ray, TB skin test or blood test, hepatitis panel. You do not want to cure their psoriasis only to give them miliary tuberculosis.
Let's wrap up the pharmacology with a few miscellaneous agents that I think are really cool. Keratolytics, salicylic acid.
The ungluers.
How do they work? They aren't just physically scrubbing the skin off.
No, it's a chemical process. The corneocytes, those bricks in the stratum corneum, are held together by protein structures called desmosomes. Think of them as protein staples. Salicylic acid works by dissolving the staples. It solubilizes the intracellular cement.
So the cells just let go of each other and shed.
They desquamate. They shed. This is great for dandruff, for the thick scales in psoriasis, for warts, or just for smoothing rough skin.
But again, there's a warning for kids, salicylism.
Right. Salicylic acid is a salicylate. It's chemically related to aspirin. If you cover a small child in a high-concentration salicylic acid preparation, especially if their skin is inflamed and more permeable, they can absorb it systemically.
And get aspirin poisoning.
They can get tinnitus, nausea, metabolic acidosis, classic aspirin poisoning, but through their skin. It's rare, but very dangerous.
That is wild. And finally, let's talk about 5-fluorouracil, or 5-FU, the destructive agent.
We use this topically for widespread actinic keratosis, those precancerous sunspots. 5-FU is what we call a false metabolite. It looks like uracil, a building block for DNA, but it's a trap.
So the cell tries to use it.
The rapidly dividing precancerous cell tries to use it to replicate its DNA, and the machinery jams. The enzyme thymidylate synthase gets irreversibly inhibited. The cell can't make new DNA, so it dies.
So it selectively targets the rapidly dividing abnormal cells.
Just like systemic chemotherapy, because it is chemotherapy, just applied topically to the skin.
And the patient experience is It's rough.
We have to prepare them for this. We tell them, you will look much, much worse before you look better. The drug finds all the invisible subclinical abnormal cells and kills them. This causes a massive inflammatory reaction. The face gets red, it crusts, it erodes. It can look like a war zone.
But that means it's working.
Yes. If nothing happens, it means either there were no precancerous cells to begin with, or the drug failed. But that intense inflammation is the sign of tumor destruction. Then it heals, and the skin is smooth underneath.
I want to close with the case study from Katsung because I think it perfectly illustrates the decision-making process we've been discussing all this time.
The patient was rosacea.
Right. A 43-year-old woman. She has rosacea, so she has papules, pustules, and redness. She was using metronidazole gel.
Which is a standard first-line treatment. It's an antimicrobial and an anti-inflammatory.
And it worked for the bumps. The pustules went away. But she was still red. She had this persistent erythema, this flushing, and she was very clear that she didn't want to take oral antibiotics.
So the clinician has to pivot. Metronidazole is great for the inflammatory papules, but it doesn't do anything to constrict the blood vessels. The redness in rosacea is a vascular problem. The vessels are dilated.
So they switched her to oxymetazoline cream.
Which is just brilliant pharmacology. Oxymetazoline is a potent alpha-1 adrenergic agonist.
It's the active ingredient in Afrin, the nose spray.
It is. When you spray it in your nose, it clamps down on the blood vessels in the nasal mucosa to stop the congestion. We just repurposed it for the face. You put the cream on, it stimulates the alpha receptors on the smooth muscle of the facial blood vessels and causes them to constrict.
So the redness physically shrinks away.
It blanches. It goes away for several hours. It doesn't fix the underlying problem, but it treats the symptom that bothers the patient the most.
And because it's topical, she avoids the potential gut issues or other side effects of oral antibiotics.
It's the perfect drug in the perfect vehicle for the specific physiological symptom. That's sophisticated dermatological prescribing.
So we've covered the fortress, the delivery trucks, the nuclear weapons, and the pipe cleaners.
We have. It's been a tour.
If listeners take one single thing away from this entire conversation, what should it be?
Respect the barrier. That's it. Do not treat the skin as a flat, passive surface. It has depth, it has metabolism, it has architecture, and it has profound variation from the nose to the toes.
And it has memory.
It remembers every time you occlude it, every time you apply a sensitizing preservative, every time you suppress its immune system, you are altering the biology of that barrier, for better or for worse.
And to really master this, you need to see the charts and the diagrams.
You do. Go to Katsun, find the chapter on dermatologic pharmacology, look at the table of steroid potencies. You need to know which ones are class 1 and which are class 7. You cannot guess.
And then go to Goodman and Gilman's chapter for the retinoid pathways. The diagrams of the nuclear receptors explain so much about why these drugs are so powerful and, frankly, so dangerous.
We've given you the map, but you still have to walk the territory yourself. The reading is essential.
Our final thought, then, is to reflect on that concept of the skin as a reservoir. It holds on to what we put on it. It releases it slowly over time. In a very real sense, it remembers the application long after your hand is washed.
A barrier that remembers.
Thanks for diving deep with us. Treat your barrier well.
See you next time.